Righty. So, welcome everyone. Just give me a thumbs up if you can see my title screen. We're good. All right, cool beans. So, welcome to tonight's installation of topics in trauma nursing. This, I believe, is the fourth topics that we have done this year, and it's basically a way for like-minded trauma and emergency nurses to get together, talk about and have somebody present a very interesting topic of interest to us, and then chat about it afterwards. And really kind of a good way to socialize, network, and get a little bit of knowledge into our heads. So I appreciate you all being here tonight, and anyone who is listening in YouTube land, thank you for participating as well. It's greatly appreciated. So my name is Steve Wyman. I am the trauma education coordinator at St. Joseph's University Medical Center in Paterson, New Jersey. We're an American College of Surgeons Level 2 trauma center. And I started this earlier this year, just again, as a way of just getting trauma nurses together periodically just to chat about stuff and learn stuff. So basically the goal of this particular program is, sit back, enjoy, ask questions, and recruit more nurses for the next session. So the more the merrier, and certainly turn people on over to the YouTube channel once I send you the link so that they can participate in this as well. We are offering CE credit tonight. So at the end, I'll flash up a QR code as well as provide a link in the chat box that you can go on and claim your CE credit. You'll also have the ability to give me your email address and I'll archive it. And that way you'll be on my invite list for future programs. And then likewise, I'll also send you a copy of the link once I post it. And you can then be fruitful and multiply if you would be so inclined. If you like what we are doing tonight, then you will absolutely love the companion to this program, which is Trauma Nursing Journal Club. This is a program we do quarterly. We pick out articles of interest that appear in the trauma literature. I do try to keep it kind of trauma nursing oriented, but every once in a while we find some good articles that come out of the mainstay trauma literature. And we basically present them in a very low threat environment. Some of the articles we present are research oriented. So as scary as that is for a lot of people, we try to walk people through and chat about not only the methodologies and how to interpret the literature, but also what the implications are for our practice. And then every once in a while, I try to do one that's just a nice clinical article that appears, and we can just kind of have a roundtable back and forth conversation about whether we agree, we disagree, why we agree, what we do at our particular facilities, yada, yada from there. So again, by acknowledging tonight and giving me your email, you're kind of giving me your permission to not only recruit you for future topics programs, but also future trauma and nursing journal clubs as well. And I appreciate that. And speaking of topics and trauma, our next session is already ready to go. It's going to be March 1st at 8 p.m. The topic is going to be ocular injuries. So we will chat about those in March. I will provide you with a link again at the end of tonight's show that you can go on and pre-register now. If not, I will also be sending out these little handy dandy beautiful flyers to everybody over the course of the next month or two for you to not only register yourself, but recruit within your own departments, within your own region, or of other like-minded trauma nurses who you think might be interested in joining us for future sessions. And that, again, is greatly appreciated. All right, so let's get the continuing education minutia out of the way. This program tonight is being accredited for both physicians and nurses. You're going to get up to one CEU for participating in tonight's program. And like I said, at the end, I will flash up a QR code for you to a smartphone or a link in the chat box that you can click on that'll take you right to the SurveyMonkey. You can complete your little evaluation, give me your email address, and then over the course of the next probably day or two, I will email you a CEU or CE certificate for suitable for framing. So hang on and hopefully you'll take the opportunity to grab some credit for tonight. So I am absolutely thrilled to have Jessica Mills speaking tonight. I listened to Jessica's presentation, the one she's giving tonight in Denver at ENA's National Conference, and was absolutely floored by just the absolute phenomenalness of the talk she gave. And right afterwards, I immediately rushed the stage, as did a lot of other people, and chatted with her a little bit, and kind of begged and pleaded with her not only to take her talk and write it up for the Journal of Emergency Nursing, where I'm the section editor for trauma, but also followed up with her to see if she'd be willing to talk tonight. And she was gracious enough to agree to do so. So I'm going to let her introduce herself in just a minute. But as you can see, Jessica is certainly an experienced nurse, and she has got the, what do they call that? Is it the pentafecta of board certifications?
High five clubs.
You're high five.
Club, yep.
Yes, right.
Yep.
So, and that's great. I think that's phenomenal. So again, we'll chat with you in just a minute about that. You can tell us a little bit about yourself and your work environment. Just a couple of real quick things. Make sure you stay on mute. I'll be able to mute you if you forget. You can certainly keep your cameras off. That's totally fine. But I would ask maybe at the end, at the question and answer session, unless you're really shy about being on YouTube, that you come on up and you can ask your questions. If you're shy and you want to ask a question, but you don't want to verbally do it, that's cool. Go ahead and put your question in the chat box. Both myself and Jessica are monitoring those, and we will make sure those get answered one way, shape, or another. At the end, we'll have an open forum, and we do want some good, lively conversation, just like we had at the end of ENA, right? I felt so bad for Jessica because she was the last talk on the last day before the closing ceremony. But I was thrilled to see that room was pretty crowded with people who were obviously very interested in this topic. And it is, in my opinion, in trauma care, a very hot topic. So, that being said, I'm glad everybody who's here tonight was able to join us. So I'm going to stop sharing my screen now. And Jessica, I'm going to let you go ahead and take yourself and put yourself into show mode. All right, you're on mute. You're still on mute.
Can you see me now?
Gotcha.
There we go. So excuse the scrubs and the no makeup, but I just came out of the trenches, just got off shift. So I'm so excited that I get to talk to you guys about one of my favorite topics, unstable bloody things. My name is Jessica Mills. I am a second career nurse. I started in 2009 as a new graduate nurse in a 9-bed ER in the rural South Carolina, where family doctors still admit, when I mean rural, I mean rural. So I spent about 2 years there with a phenomenal slave driver of a preceptor that really just molded me and sent me in the right direction. So about 2 years after that, I went to our local level 1 trauma center. We were ACS level 1 and PEDS as well, a trauma center. Spent about 10 years there in the trauma center as a trauma nurse and a charge nurse, helped create a trauma nurse leader program, got to play a big part in that. Over the past few years, I've achieved the high five, got all the BCN certifications, just trying to learn more about our patients and what they go through in transport and multiple aspects of. So last year, actually a year ago today, I went back to my little rural hospital. We have upgraded to 12 beds. Family docs still admit. So literally the ER doc is the only one in the shop. So I have went from rural to academic, back to rural. So I've kind of been a little in between. I spent about a year and a half in COVID ICU as well. So trauma is my passion. It has been for a long time. I love what we do. We get to serve people on the worst day of their life and hopefully make a difference. So as Steve said, this topic is a hot topic in trauma right now. ENA, just to kind of get nurses on board with this, that the docs are starting to learn a little about this. The evidence is there, just to bring it up and put it on the forefront of nursing as well. So my favorite thing besides my children and my family, trauma triad of death. So let me get my little screen to work here. There we go. All right. So we've all seen the trauma triad of death, the trifecta of the dying trauma patient. Ooh, sorry, clicked the wrong thing. So that's the coagulopathy, the acidosis, and the hypothermia. It was actually originally named by the American Trauma Society in 1982. It was named the Bloody Vicious Cycle. I feel like we should speak that in a British accent like Monty Python, but so that's how it was originally named back in 1982, and it's become our basis for damage control resuscitation. So we're going to talk a little bit about each leg of the triangle and how that I think that in the near future that it's not going to be the triangle anymore. It's going to be the great diamond of death. So let's go on in, and first of all, let me get you guys over here so I can see. We're going to talk about acidosis. So what is acidosis? Just a textbook simple answer to that question is it's a lack of perfusion. So lack of oxygen at end organ tissue or at end organ level or at tissues. So in acidosis is going to cause the patient to flip into an anaerobic metabolism because in that oxygen deprived state, lactic acid is going to begin to form. So these patients are going to flip into an anaerobic metabolism. Lactic acid is going to build up and there's going to be an even greater lack of perfusion there. So what is acidosis? A normal pH is 7.35 to 7.45. So acidosis is anything less than 7.36. What causes acidosis in the trauma patient? Two things. In every aspect of the trauma triad of death, we're going to talk about two causes. Number one, the trauma itself. Number two, the treatment. So the trauma itself causes acidosis because how do trauma patients die? They bleed to death. They lose volume. So they're hypovolemic. They're losing the volume. If there's not enough blood to circulate to perfuse those end organs, poor perfusion is happening. There's a decreased cardiac output because we all remember that equation, the cardiac output, stroke volume, heart rate. So there's less stroke volume. That heart rate has to go up to keep up with that cardiac output. But if these patients are bleeding, they're going to have a decreased cardiac output because the tank is empty. So we're going to also have peripheral vasoconstriction due to hypothermia, which is another leg of the trauma triad death that we're going to talk about in a bit. So also the trauma itself causes the acidosis, the treatment causes acidosis. So what do we do with our hypotensive trauma patients? You old folks in the room, remember back when we used to give our trauma patients 6 and 8 liters of crystalloids to fill the tank? So what are we doing with these patients? We're giving them acid water. We're giving acidotic patients acid water. So the pH of normal saline, 5.5, literally fertilizer. LR at least has a pH of 6.5. So by treating our patients, we're causing a worsening acidosis, which is one of the 3 things that is known to kill the trauma patient. So again, trauma causes the acidosis and the treatment that we provide causes the acidosis. Alrighty, so we talked about the causes. Let's talk about the effects of acidosis. What does it look like in our patient? What does it cause? It causes a reduction in coagulation factor activity and an increase in coagulation times. Usually our trauma patients are going to be in that metabolic acidosis because they're going to have volume loss. So volume loss, not enough blood in the tank. Those end organs, the end tissues are not being perfused with that good oxygen-rich hemoglobin. Lactate starts to build up and they're going to be in that metabolic acidosis. Or occasionally our patients can be in respiratory acidosis or mixed acidosis. So why would our patients be in respiratory acidosis? Hypoventilation, which can be caused by traumatic brain injury. These patients are unable to ventilate and cause good gas exchange. And we all know our trauma patients are occasionally drunk. So when you're incredibly drunk or high on drugs, you're not able to ventilate as well, which could cause a respiratory acidosis. Underlying medical conditions like COPD or a traumatic flail chest can cause respiratory acidosis as well. All right, trauma-induced coagulopathy was first discussed in the Korean and Vietnam Wars when they realized, hey, these patients are bleeding like stink and we can't make them stop bleeding. So there's another name for it. It's either TIC, trauma-induced coagulopathy, or ACOTS, depending on your research, the acute coagulopathy of trauma shock. Basically, these patients are bleeding and we can't stop it. When does this start? It occurs within about 30 minutes after the trauma itself, and it's from hemorrhage and tissue injury. So essentially, you were born with this many clotting factors, okay? Your trauma happens and your body goes, activate the clotting cascade. Let's go clot things that are bleeding. So your body uses up all that it innately has and can't make enough to catch up with the bleeding that's happening during the trauma. So therefore, there's an imbalance between clotting, anticoagulation, and fibrinolysis. Essentially, your body cannot clot where it needs to, and it's clotting inappropriately in places where it doesn't need to. So the clotting cascade is abnormally activated. There's excessive clot formation in some places. There's breakdown when there shouldn't be. It's out of proportion to the injury. And the body rapidly consumes the clotting factors that you innately have, can't make enough to stop the bleeding during the trauma. So this is a busy little slide that I really like. If you look here, so it talks about the trauma tissue injury, how trauma itself causes the trauma-induced coagulopathy. And then it talks about the hyperperfusion, the trauma itself causing the coagulopathy, the inflammation, that inflammatory cascade started, the comorbidities, genetic factors, and then it also talks about what we do to our patient. Again, the dilution, we're diluting out that oxygen-rich hemoglobin that the patient does have left with acid water, okay, causing acidosis. Again, we'll talk about hypothermia in a bit. So they're cycling into this trauma-induced coagulopathy and hemorrhaging even more because of the trauma and the treatment that we provide. So resuscitation-induced coagulopathy, again, we are pouring acid water into our patients, hemodiluting what oxygen-rich hemoglobin they do have. IV fluids are acidic, it's causing them to become more cold, and we'll talk about how hypothermia affects the coagulation as well. So cold patients, why are our trauma patients cold? We're going to talk a little bit about it. So core temp under 95 degrees Fahrenheit is what is considered hypothermia in the trauma world. Why are they cold despite the environment? I live in South Carolina. It is 157 degrees sometimes in the summer here. It makes Satan sweat. Why are my trauma patients cold when they're coming in out of the southern heat? Traumatic brain injuries. These folks cannot regulate their vital signs. They can't regulate their temperature. Alcohol, no way, not our trauma patients. The trauma patients may be high on drugs, they may be drunk with alcohol, hemorrhagic shock, so that lack of perfusion. There's not enough blood in the tank to circulate that oxygen-rich hemoglobin, therefore they can't maintain their core temperature. So why is hypothermia so important? Why is it so important to have that room warm, to cover that patient up? Because it affects hemostasis. How? There's a reduction in local vasoconstriction. And there's a reduction in platelet aggregation at the site of the injury. So these patients are not vasoconstricting to shunt blood to the important places, and they're not able to clot appropriately at the site of injury. So the coagulation cascade is actually dependent on pH and temperature. That sounds familiar. It sounds like the trauma triad of death. Coagulation depends on temperature and acidosis. It depends on pH. So this shows how the trauma triad of death feeds off each other. One is dependent on the other. Therefore, when one crashes, others will crash as well. So hypothermia also causes a leftward shift of the oxygen hemoglobin dissociation curve, which really just means there's a reduction in myocardial contractility. The heart can't squeeze as effectively, it decreases perfusion. There is a reduced tissue oxygenation. Essentially, the tissues need more oxygen and the body doesn't have any to supply. So you end up with an increased state of oxygen debt. What is an increased state of oxygen debt? Acidosis. Lactic acid is spilled out exponentially, and your patient becomes more acidotic due to their hypothermia. So hypothermic patients, there are multiple studies that show cold patients are more likely to die. Okay, something very simple that we can do, because cold patients don't stop bleeding. They can't activate their clotting cascade. They become more acidotic because of the increased state of oxygen debt. All right, so why do I think that we are going to eventually switch the triad of death to the diamond of death? Because calcium is my favorite thing. I'm going to show you why it's valuable in the trauma world. So I think we're going from the triad to the lethal diamond. So let's talk a little bit about calcium and what it does. All right, so the calcium's role in the coagulation cascade. If you notice here, calcium activates the thromboplastin, multiple clotting factors. Then calcium is used to convert prothrombin prothrombin to thrombin. So it contributes to platelet adhesion, calcium does. It's required to activate the clotting cascade with these multiple clotting factors that are important for clot formation. Thrombus formation, the calcium aids in stabilizing the clot itself. Calcium is also important. Remember, in ACLS, we give calcium during cardiac arrest. Why? Because it aids in myocardial contractility. So a lack of calcium would cause a decrease in myocardial contractility. Smooth muscle cell contractility as well. So how do we measure calcium? There are two ways to measure calcium. We're going to talk about two, and then I'm going to talk to you about the one that's most readily available and the one that we're going to see in the majority of the studies. So ionized calcium is biologically active. It's the most helpful lab, but it's usually a send out. So we're not going to have that during a trauma resuscitation. So a normal ionized calcium is 1.1 to 1.35. The total serum calcium is going to be the one that's probably available in your shop. However, there are some disadvantages to it because it can be falsely low if your patient has low albumin. So you think about all the grandmas that fall that have baseline low albumin. This is not going to be quite as reliable because calcium is transported by albumin. Half of the calcium in the blood is bound to albumin. So if a patient has a low albumin, this is going to be a falsely low calcium. So serum calciums in adults are 8.9 to 10.1. So what's normal? Let's look at both of these, ionized calcium and serum calcium. Normal here. All right, so hypocalcemia and the ionized calcium is less than 1. Severe hypocalcemia is less than 0.9, so low is bad. Serum calcium here, so the hypocalcemia and the severe hypocalcemia for the serum calcium, less than 8. And we'll look at those in some studies here shortly. So what causes hypocalcemia in trauma? Don't you love a good bloody picture? I love a good bloody picture. So again, like we talked about before, the trauma itself, the treatment is going to cause hypocalcemia and trauma. So let's talk about the trauma itself. Calcium is bled out when blood leaves the body. So when these patients are exsanguinating, number one cause of death in the trauma patient is exsanguination, loss of blood. So when you're bleeding out calcium. Serum calcium drops, the coagulopathy worsens, the hemorrhage itself worsens. And then how does a treatment cause hypocalcemia in the trauma patient? Blood products. So I don't know why that's cut off, but it is cut off. Citrate is used as a preservative in packed red blood cells and FFP. Each unit of blood product that you use is going to have 3 grams of citrate. Citrate chelates calcium in the blood. It essentially strips the calcium out of the blood as it circulates. Citrate is metabolized by the liver and then converted into bicarb. So here's the issue. If you have a sick trauma patient and they're hypoperfused, the liver is going to also be hyperperfused. So citrate can be easily metabolized, usually 3 grams in about 5 minutes. But in the hypoperfused trauma patient, that's not going to be the case. I don't know why this is acting funky, but all right. So there will be decreased liver function due to hypotension and hypothermia. So the more blood you give, the more hypocalcemic your patient's going to be, because you give blood, it literally strips the calcium in the blood. So as the citrate goes around in the body, it pulls the calcium with it, so it's not readily available for use. So 1 unit of blood can drop calcium, 1 unit of blood. So how do we give blood in the sick trauma patient, the 50s over 30s that need that massive transfusion? We activate the MTP, we give the blood fast. So a hyperperfused liver can't metabolize that citrate. So essentially the treatment that we're giving is causing severe hypocalcemia. So hypocalcemia is shown in multiple studies to cause increased morbidity and mortality. Interestingly enough, in the trauma world, we use something called the injury severity score. So despite how sick your patient is, despite their injury severity score, hypocalcemia causes increased mortality. Hypocalcemia causes cardiac dysrhythmias because we know from the ACLS world that calcium is necessary for cardiac contractility. Hypocalcemia causes impaired cardiovascular function, a narrowed pulse pressure, and circulatory depression due to decreased ventricular activity. That heart's not squeezing, it's not pumping, it's not good at getting oxygen-rich hemoglobin all over the body, because the heart itself can't function without calcium. It also causes hypotension due to decreased vascular resistance because we don't have that calcium to assist with the vascular walls. Causes poor vascular tone and poor clot strength. As I mentioned before, the clotting cascade to be activated depends on temperature, depends on pH, and calcium is needed to activate that clotting cascade. So in a hypocalcemic environment, these patients are going to have poor clot strength, which we all know is bad for our patients. So how does hypocalcemia affect trauma patients? As we know, in the trauma world, usually the military is about 10 years ahead of us. Mass trousers, tourniquets, pre-hospital blood, all of those things came from the military. There's a bunch of guys being injured, and there's Uncle Sam that can pour money into the research. So it would behoove us in the trauma world to always look to our military brothers and sisters for the research that they are doing years ahead of us. So let's look here. Cherry et al. Had 396 patients. Look at this mortality for a calcium less than 1, and the mortality for calcium, a normal calcium. Mortality for a low calcium was 26.4%. For normal was 16.7%. We look down here at Magnati, we see a similar trend. Low calcium, 15.5. Normal calcium, 8.7. Interestingly enough, hypocalcemia can also be a predictor of a need for a massive transfusion for the patient. So look over here, greater than the patients in the Magnati study that needed greater than 5 units of blood products, 17% of them had low calcium, only 7% had normal calcium. The folks that needed greater than 10 units, 8.2% of them had low calcium, only 2% of them had normal calcium. Seeing a trend? Let's go down to one more study. Look at that difference, mortality from 25 to 15%. In the transfusion, the need for a massive transfusion, 62.5% of those patients had low calcium that required the MTP. Only 37.5 had normal calcium. So again, we see a trend. Morbidity and mortality is increased with hypocalcemia. The need for multiple blood products can be predicted by hypocalcemia as well. So how does hypocalcemia, if it's going to become a diamond, how does it affect the other parts of the diamond? Hypocalcemia affects coagulopathy because it impairs the clotting cascade, causes prolonged clot formation. The clotting cascade can't activate properly without calcium. How does it affect hypothermia? It decreases the liver's ability to metabolize citrate. So more calcium is bound and less is available in the blood. That citrate's going around and around and around, stripping the calcium in the blood as it circulates because a hypoperfused liver can't metabolize the citrate. It also causes worsening acidosis because it affects the coagulopathy, affects the hypothermia, lactic acid continues to build, and our patients get sicker. So what do we do with this? Replace the lost calcium. It's just not complicated. Patients without calcium die or need more blood, have worsening outcomes. So give them some dang calcium. How do we do it? So again, there are mixed opinions on how it should be done, gluconate versus chloride. So we're going to talk a little bit about both. Calcium gluconate gives 8.9 milligrams per milliliter of essential calcium. Calcium chloride is 27.2 milligrams per milliliter. Calcium chloride is ideally given through a central line, but let's all be honest, would you rather have an extravasated, calcium through a peripheral line or a dead patient? I would rather recover that vasculature. If all you can get is a peripheral line and all you have is calcium chloride, your risk benefit has to be weighed there. So follow your protocols, whatever your shop set up, follow your orders. But seeing the importance of calcium, I hope will open your eyes here shortly. So there's disagreement over timing, dose, and gluconate versus chloride, of course. Kyle et al. Looked at the impact of pre-hospital blood given or pre-hospital calcium given with blood products and discovered, again, using our military brothers and sisters, 297 military combat trauma patients received an average of 4 units of blood were given for pre-hospital. So let's look at this. The treatment group got 10 milliliters of calcium chloride plus the blood. 28% of those guys arrived to their facility hypocalcemic. The non-treatment group that got blood only, 70% of these guys arrived to their treating facility hypocalcemic. And we've seen the detriment the hypocalcemia is definitely a detriment to our trauma patients. So just with that 10 milliliters of calcium chloride, look at the difference, 28% versus 70%. So calcium replacement protocols, we're going to talk about a few. The European Guideline on Management of Major Bleeding and Coagulopathy and Trauma suggests that we monitor the ionized calcium levels during a massive transfusion protocol and correcting calcium into normal limits. So fix the calcium. Obviously, you're going to, as with any nursing intervention, you're going to reassess. So we are going to replace the lost calcium to get the calciums within normal limits, and then we're going to continue to monitor during that MTP to make sure the calcium stays within that normal range. 97, if you're going to listen to anything I say, 97% of trauma patients have hypocalcemia within 24 hours of the MTP. We've seen what hypocalcemia does to the patients. 97% of the patients that we are resuscitating with a massive transfusion protocol are going to have an episode of hypocalcemia. So calcium replacement protocols. Dickerson et al. Uses calcium gluconate 4 grams for every 2 to 4 units of PRBCs. Another study used 2 grams of calcium chloride after 2 to 4 units of PRBCs. My favorite is the calcium replacement protocol is a joint trauma system. U.S. Military Protocol Clinical Practice Guidelines says that 1 gram of calcium, either calcium gluconate or chloride, we're not going to fight over it, just pick one, should be given to patients in hemorrhagic shock during or after the first unit of blood. So these guys are not waiting until 4 units of blood are needed. If those clinicians predict that a patient's going to need a massive transfusion, are going to need multiple units of blood, they start the calcium with the first unit of blood because they know what hypocalcemia does to these patients. So pick one, give it with your blood. I like this because it's simple and it starts the treatment early. So you give the calcium again after 4 units of blood. So give it with the first, and then you give it again after the 4. So calcium replacement protocol, does your shop have one? I've found through reaching out to friends in the trauma systems throughout the South that not many folks have a calcium replacement protocol in their massive transfusion protocol. Usually it's the nurse, and that's why this was so important to me. I wanted the nurses to be empowered to say, hey, doc, you want to replace some calcium now that we've given 18 units of blood? I've given 25, 30 units of blood and not replace calcium. So the treatment that we're providing can cause harm if we're not replacing the calcium that we are causing to be chelated as we're given those massive transfusion protocols. So some management of the lethal diamond: stop the bleed, put a finger in it, put a tourniquet on it, however you need to do it, stop the bleed. Humans don't bleed acid water. Replace lost volume with what the patient's lost. They've lost blood. Warm your patient. I don't care if you're sweating. The room needs to be hot. The patient you expose and then you recover. Warming that patient makes such a big difference. The warm blankets that we're constantly going to get get our normal little ER patients really do save patients' lives. So strip and flip, keep the patient covered as much as possible. Allow for permissive hypotension in your bleeding trauma patient, except for your head injured patients. 1 episode of hypotension in these patients can be detrimental for them. So we're going to oxygenate these patients, ventilate if necessary. If you're worried about that respiratory acidosis or respiratory depression, we may have to ventilate to provide adequate oxygenation and ventilation. Treat the causes of the hypoventilation to prevent multiple types of acidosis. Your shop may give TXA. If it does, follow your protocols for your TXA, and then calcium replacement. If you don't have a calcium replacement protocol, talk to your trauma team about it. If that's not an option, if you're at the bedside, hey doc, I've given 2 units of blood. I don't want this calcium or this patient to be hypocalcemic. What do you think about calcium? Just throw it out there. So the trauma diamond of death, again, the hypocalcemia fuels all of these things, which we have shown all feed off of each other. So if 1 amp of calcium can make that much of a difference for these patients, I think it's worth asking about. Lots more research to be done, but it definitely is a hot topic in the trauma world. And I wanted us as trauma nurses to be knowledgeable about what's coming for our patients. Lots and lots and lots of references. I don't mind sending you guys. If you have any questions or if I can be of any help with, there is my email. So there we go. Any questions, guys? Y'all, let me see if we got any in the chat. Jessica, how soon in the resuscitation might you see hypocalcemia? At what point should the measurement be done? Do you measure off the initial baseline? So these folks are arriving to our shops hypocalcemic. A good 60–70%, depending on the research that you look at, these folks are arriving hypocalcemic. So I have even begged to question, if our EMS brothers, they're given pre-hospital blood, the critical care EMS folks in my shop, they actually implemented, after hearing me speak this at an EMS conference, they actually implemented a pre-hospital calcium replacement protocol with their first unit of blood. So I think that the measurement should be done off the baseline. I think it should be part of the trauma orders. Everybody gets their CBC, their CMP, their alcohol, their all the things. Throw calcium in there. Let's look at it. Will acidosis and the lethal diamond affect TXA? So my trauma center that I spent a decade in, our trauma surgeons were, there's a lot of on the fence with TXA. Some people are in agreement, some are not. My guys were anti-TXA. So I don't have an answer to that because my guys were, they were not pro-TXA, so we didn't use it frequently. So does anybody have a calcium replacement protocol in their shop? You're looking at the calcium replacement protocol at my trauma center. It was me going, hey, doc, let's get some calcium. Okay, whatever. Give the calcium.
Jessica, do you have a written protocol at your institution now?
At the trauma center that I spent 10 years at, we did not. We literally, I made see, I like to do these things. I asked for forgiveness, not permission. I made a little laminated thing. It said, don't forget the calcium, and literally taped it on our rapid infuser. So the nurses would remember to say to the docs, hey, guys, there's this calcium note here. Do we want to do something about that? I was actually only able to find one hospital in South Carolina that had a calcium replacement protocol with their massive transfusion protocol. So it's just not in writing. We're all about making these MTPs, which are hugely important. Let's resuscitate the bleeding patient with blood, but let's also not kill them in the process with our treatment. And calcium's cheap. Everybody's got it. Crack your crash cart. It's right there. It's not some expensive thing that we're going to have, like Case Central, we're going to have to spend 10 grand on. Everybody's got it. It's in the back of every ambulance. It's in every crash cart. So that's why I think this is so doable for us. And it's going to make a huge difference in the morbidity and the mortality of our trauma patients. So there's my little soapbox.
It's a great soapbox. I can tell you in our shop, we don't have a written protocol. It's part of our 2023 list of things to do, but
yes,
we have become much more cognizant of when we're resuscitating our trauma codes, which is our higher level. And those are the ones that are going to get the blood components and the whole blood coming down into the trauma bay. We're much more cognizant now, both on the nursing part and on the trauma surgeon part, of giving a gram of calcium after every couple of units of whole blood, or a couple of rounds of component therapy. So we're there. I mean, I'd like to say we're doing it universally across the board. We're not, and I think a protocol is there. And I like your concept of popping something up on the transfuser. Have you checked your calcium lately? Something like that. I think that's a phenomenal idea.
Don't forget about the calcium. And why is this not in our MTP? It's something that's so simple. That way, if the nurse is busy and forgets to ask, it's already, when they deliver the cooler, there's an amp of calcium taped to the top of it. Like, it really can just be that simple if it's written into your MTP protocol. Right now, I work in a small shop, again, my little 12-bed ER with my ER docs, my family docs admitting. We don't have a massive transfusion protocol. So it's up to me even to initiate that, and then to say, hey, doc, we've used the whole 6 units we have in the hospital. Can I give some calcium while we're getting the heck down the road? So I really just wanted to empower the nurses with the knowledge to approach the providers to say, hey, there's this wild chick, General Mills, that said this calcium stuff really makes a big difference. I've read a little bit about it. Do you want to give some? So tons of research out there coming. Our military brothers and sisters are 10 years ahead of us on this, and they've shown that it really works. Something cheap, simple. And what happens if you give somebody calcium and they don't need it? Nothing, unless you give them, a case of it. But if you give them 1 amp and they don't need it, you're waiting for that calcium to get back from the lab. I just don't see the detriment in it. I don't think you're going to cause harm, even if they don't need it. So lots more to come, but cutting edge stuff in our trauma world that's coming down. And I wanted you guys to know about it so we can, advocate for our patients at the bedside, even if it's through a sticky note on the rapid infuser.
In your couple of articles where you talked about the fact that serum calcium actually was somewhat of a predictor for the need for mass transfusion. Did they kind of give a theory as to why they thought it was it just pure consumption of calcium because they were bleeding out, and when you bleed out, you start going through and using the coagulopathic factors start binding and using a lot of calcium. Not to mention the fact in some of these settings, if you start to give 1 or 2 units of blood or component therapy with the citrate, you're starting to bind up calcium. But were they looking at more? It was a consumption thing, and because the body was going into shock, was consuming more calcium as part of the coagulopathic factor or the coagulopathic pathways, that was kind of where they were kind of leading as a predictor?
I don't think that they really pinned it down to the why. For me, the logical answer is the trauma triad of death. Those 3 components that were before the hypocalcemia leading to the lethal diamond. They all feed on each other. So if that patient's hypocalcemic, the other 3 branches of that diamond are going to be worse. They're going to become more acidic if hypocalcemia promotes that. So not any specific, but I think it's just because they all tie together. If the patient's hypocalcemic, they're going to be more acidotic. They're going to be more coagulopathic. They're going to be colder. So one causes damage to the other, and it just is a circle into death.
Yeah, good point. Hey, Kevin, just to kind of circle back around with your question about TXA and acidosis, there's not been a lot in the literature that I've come across that really talks about the impact of pH on the actual, if you want to say the utilization of TXA. I could certainly say in particularly a lot of the studies they've done, these are patients that are in shock. They are going to be acidotic. So by convention, they're going to be acidotic. And apparently, again, they got the positive results out of TXA that they did get, both out of CRASH and MATTERS and the the assorted studies to probably lead us to believe that TXA is probably not that tremendously adversely affected by pH, but I certainly don't think the research is out there to say one way or another whether it
right.
It's ardently impacted or not.
Yeah.
Anybody else have any other questions?
Thanks, Steve.
Absolutely. All right. Well, you certainly have Jessica's contact information. It's here on the slide. I'm going to pop up real quick, go back to boom and boom. So you should be going from Jessica's screen to my screen now. And so if you are so inclined, here's a QR code. If you want to pop out your smartphone and snap the QR code and get right into the survey, feel free to do so. In the chat box is also a link that'll take you into the evaluation. Again, fill it out, get your CE credit. I'll send you a certificate within the next couple of days. And also, if you are so inclined to want to participate in future incarnations, both of this particular program or the Trauma Nursing Journal Club, pop your email address in there and I will add you to my ever-growing list of like-minded trauma nurses that want to participate in this program moving forward. And also, shameless plug number 2, also in the chat box are links for registration to the next iteration of both the Trauma Nursing Journal Club on February 1st. The topic for that is going to be pelvic compression device binder application training in medical students, a mannequin study. Another, I'm not going to say it's a hot topic out there right now, but a bit of a interesting topic out there right now is the use of pelvic binders. When do we use them? When don't we use them? And ultimately, how do we build competence and confidence in using them? And even though this is a medical student driven analysis, it's actually pretty interesting. So I'm going to use that as the fodder for the next journal club. So if you do have a burning interest in pelvic trauma or pelvic fractures and pelvic binding, then this is right up your alley. Secondary to that, in March 1st at 8 o'clock, we'll be having the next topics in trauma nursing topic, which will be ocular injuries. Everybody cringes at a good eye injury. So we're going to go over 9 of the more common and more serious eye injuries that you can encounter in the emergency department, and chat a little bit about them and make people a little smarter and a little more confident in their treatment of ocular injuries when they present into the emergency department. So without further ado, does anybody else have any questions? All right, well, cool beans. Well, I appreciate everybody coming in tonight. I appreciate your participation in tonight's topics in trauma nursing. And thank you, Jessica, so much. Again, another fantastic presentation. And I look forward to working with you as we develop this into a full-fledged article for the Journal of Emergency Nursing. But everybody else out there, thanks for your time tonight. Happy holidays to everybody. And I look forward to hopefully seeing you at future iterations of these programs in 2023. So have a great holiday season and take care. Be safe.